Aloha, my name is Josh Green. I'm your host at Healthcare in Hawaii, here with ThinkTech Hawaii. Thank you for joining us again. As you know, these past several weeks we've begun a program to explore the entirety of the healthcare system in the state of Hawaii. A lot of these issues are very complex, and we've been lucky to have experts from across the spectrum of health. We had Beth Giesting, who's the governor's coordinator for healthcare, the health czar. We had George Green, who represents the Healthcare Association from Hawaii, Hilton Rathel, the Senior Executive Vice President over at HMSA. We had Jairus Hedges, the Dean of the Medical School. And today we have a really highly esteemed guest, Dr. Linda Rosen. Dr. Rosen comes to us with a great deal of expertise, both in clinical healthcare and now in administrative healthcare. Linda worked as a pediatrician here for years, but now she's the director over at the Department of Health. Linda's the Chief of Emergency Medicine for medical services and injury prevention for the entire state. So I want to introduce you to Dr. Rosen, to Linda, and first get a little bit of her background. Linda?
Thanks very much, Senator Green. I'm really flattered to be here today. I've been at the Department of Health about 13 years, and I really love public health. And I find that the work that I do there really builds on the previous work that I did as an emergency physician, like you at Kapiolani Women's and Children's, doing critical care and emergency medicine. And while I was there, I got involved with the Keiki Injury Prevention Coalition. I got interested in injury prevention and public health, and I eventually made my way to the department 13 years ago to have sort of, I think of it as my second career, or second phase of my career in public health.
See, this is very exciting for me, because I love to see people, when they get into a health policy, to be well-grounded like you were. So you were able to actually see healthcare on the ground at Kapiolani Women's and Children's, and then you're taking those experiences to build out larger programs. Tell me a little bit, just give people a background about what your department does. I mean, what's your role in the state?
Well, right now I'm Chief of Emergency Medical Services and Injury Prevention System branch for the Department of Health. And our branch has three major areas of responsibility. One is the emergency medical services, which are all the ambulance services statewide. People may not know that all 911 ambulances pay for and contracted at the state level out of our office. Mm-hmm. And we also bill and collect, not as popular as providing the service, but that's our responsibility too for ambulance services. And we also have our trauma system, which I know we'll talk a little bit more about today.
Absolutely.
And injury prevention, which actually is part of a trauma system. Those are the major areas of responsibility in my part of the department.
Why don't you start us a little bit about describing what trauma means? I think that a lot of people, I mean, you and I work in the field, of course, but I think it'd be good to give that grounding. So when you say the trauma system, how do we define a trauma in our state?
Well, trauma is a word that can have many meanings in different contexts, but in the context we're using it, it really means injury. So when we say trauma, we mean injury. And injury can be, you know, the things we typically think of, like motor vehicle crashes and falls, but it also includes drowning and poisonings are also forms of injury. So a trauma system seeks to prevent and control injuries to our community.
Got it. So, okay, so you're in charge of the trauma system. Now, I think one of the challenges we would all agree is we have a very unique geography. We have multiple islands and we have really rural areas. Tell us a little bit about how you deal with this. I mean, how have you begun to create a trauma system? Where did it start, I guess, when you first came to Department of Health and your job? Where is it now? Tell us a little bit.
Well, the trauma system is pretty new in terms of building it out, although it's been talked about and planning's been done for maybe 20 years. But it wasn't until we got some funding a few years ago that we were really able to make progress. But a trauma system seeks to bring all the components together to control injury. We call it the whole public health spectrum, from prevention, things like seat belts and part of preventing injuries, right, and all the way through the types of services, hospital, ambulance services, and then on to recovery, where patients need sometimes rehabilitation and assistance in order to return to their daily lives.
So I think in the public, people hear the word trauma and they think of maybe that old show, ER, right? People show up at the ER and there's been a terrible car accident or there's been a gunshot injury or whatever. What is trauma really like? Is it like that in the ERs? Is it like that at Queens? What's it like for people day to day?
Well, of course, at Queens Medical Center, which is our highest level trauma center, they're a level 2 trauma center for the state, you can get some of those very dramatic, exciting, tragic events. But injury is, there's a lot sort of below the tip of the volcano on the impact on society in terms of a lot of emergency department visits, a lot of hospitalizations, as well as the big tragic injuries. But as you know, working even in a rural hospital, you never know what's going to come in, either, just driving up, bad injuries, and of course it's very, very challenging to do everything you need to do quickly to stabilize and evaluate those patients.
The other day we had a guy come in to the ER out in Kohala, very little ER as you know, and he slept it off. He had probably some alcohol the night before, and he had bumped his head, came in with a headache, didn't know what happened, and had some blood in the back of his head, and the nurse cleaned him up, and we got there to look, and he was missing a large piece of his skull, and his brain was exposed. And he was actually walking and talking, and we were quite stunned. And it was just one of those, he walked into the ER, and he had suffered, it turned out, he didn't remember it, a severe injury. Someone had banged him over the back of the head with a metal pipe, I think it was, and he actually lost a piece of his skull. And then we activated the trauma system. So yeah, in this particular case, we called Queens, and one of my colleagues called Queens, and they got the whole system activated, and we first transferred him to North Hawaii, where they did a CAT scan, which we didn't have at our little hospital, and then from there, they airlifted him over to Queens. Now, walk us through that. Are these hospitals all part of the trauma system, or how does that work?
Yeah, I think taking that example, I could sort of describe how we connect all the different facilities. We have what we call an inclusive system. That means every hospital has some role, although of course they have different capabilities. So the smaller hospitals, the critical access hospitals like North Kohala are part of our system. They have been provided some modest funding, primarily to educate their staff and assist with equipment. And we call them trauma support hospitals. They're the sort of lowest level, but important part of the system.
And now what do they have? They just have like a guy like me, like an ER doc?
They have a physician that's available to evaluate patients. They have staff, nurses. They generally have x-rays and limited labs, but they don't have CAT scans, and they don't have a lot of more sophisticated inpatient services available. So a seriously injured patient really couldn't be kept at one of those hospitals, and we would expect them to go to a trauma center.
Right.
Now the trauma centers come in levels 1, 2, and 3,
yes,
with 1 being the highest and going down. Now on the neighbor islands, what we've been able to do is establish level 3 trauma centers where we had none before. Before we started in 2009, we only had Queens was the only verified trauma center in the state of Hawaii.
What level was Queens at that time?
A level 2. And they were verified. The American College of Surgeons Committee on Trauma is like the organization that sets sort of the standards and comes out and reviews and approves prior to the state taking a role. So we had Queens, but we didn't have anything else.
So the rest of the hospitals around the state at that time, and it's really not that long ago, like 4 years ago, they had freestanding emergency departments or emergency departments that were part of their hospital. They had some ER docs and maybe a surgeon around, but they didn't have certification. Is that what you're saying?
Right. And so, the resources, we are trying to add some resources to the system, but for the most part, these hospitals have very similar resources to what they had before. It's now that it's just that they're organized into a systematic approach to the patient, and data is collected, and they're constantly evaluating their care. So the standards include things like when certain criteria met, say the patient has very severe injuries, is unstable, of course you want the surgeon to be there quickly. So one of our standards is that the surgeon will be present within 30 minutes of activation.
Okay.
Now that doesn't mean for a stubbed toe. In other words, it has to be one of these higher levels of injury, but then that's a standard, and the hospitals are meeting those standards. They have to be able to get all the studies in a very timely fashion.
When you say studies, you mean the tests?
Yes, lab tests and CAT scans or whatever it might be indicated for that particular patient, so they can understand, if there are life-threatening injuries present, what might need to be done, or whether the patient might need to be transferred to a higher level of care. And so level 3, we now have level 3 trauma centers on all of our major islands. And so the Big Island on Hawaii, as you know, you mentioned North Hawaii. We also have Hilo and Kona now as level 3s, and my Memorial Medical Center and Wilcox on Kauai are our level 3s on the neighbor islands.
So that gentleman that came in and had the injury to his head and damage to his skull, now that we quickly transferred him to North Hawaii, they activate their trauma team and their level 3 trauma center. They do what they do. They call their surgeon, they get all the tests very quickly, and they determine that, oh geez, this is a bad situation. We don't have a neurosurgeon, for instance, there at that hospital, or on the island for that matter. Then how does it work to activate them over to Queens, our level 2 trauma center?
Well, before I answer that, I just want to mention one of the great things that's come out of the trauma system, since you mentioned somebody with a head injury, and that is we've actually developed guidelines to assist the hospitals in identifying which head injuries will need transfer, require a neurosurgeon. As you know, we don't have neurosurgeons on the Big Island or on Kauai for that matter. And so we've developed some guidelines so that they can determine which patients definitely need to come over and which they might consider keeping, but then again, it depends on the resources of each individual hospital. So getting back to your question, once the decision is made to transfer the patient, then they have to figure out how.
Right.
Because we're a trauma system, if it's a trauma patient, it needs to go to another trauma center, either a higher level, or sometimes there's a trauma center that just doesn't have a particular resource. For instance, a patient at North Hawaii might be transferred to Maui for a plastic surgery repair of an eyelid or something like that. So it's not always to the higher level. But that's one of the advantages, is that if one hospital has what another hospital doesn't, it's an automatic accept, which, as you know, being an emergency physician is really nice to be able to know that you got a place for your patient to go to.
Sure.
So, of course, we're an island state, so we've got big bodies of water between our hospitals, so it is challenging to transfer patients. And most patients will be transferred by airplane, by air ambulances, what we call fixed wing. Those are planes as opposed to helicopters, which are rotor wing. We do have a few helicopters also in the state that can transport our trauma patients. We have a helicopter on the Big Island that's part of the 911 system that can respond to the scene, but they don't transport off of the island of Hawaii. And then we have a 911 helicopter for Maui County that does transport within Maui County and can also go to Oahu, and they can take trauma patients. We don't have any helicopter service right now on Kauai, or air ambulance that is, on Kauai or on Oahu.
Got it.
Yeah.
So, okay, so let's come back to that patient before we take our first break. They've seen a doctor or a set of doctors at the level 3 trauma center, and they've stabilized the patient, they've gone through the process. These are evidence-based protocols that you put into place, so we now know how to better care for that patient. But if they still determine they need more care, that's when they activate the next level, and they would then contact the air ambulance?
Yes, so they would arrange for the accepting hospital and get the air ambulance and to come and help get the patient to the airport. Now, sometimes the airport is far from the hospital. That's been a challenge, as you know, on the Big Island, because Kona Hospital is about 45 minutes from the airport.
Right.
Really added a long time to transport. They now have a helicopter at Kona Airport that's able to fly up to the hospital and pick up patients. So that's something kind of new.
Excellent. Well, I think this is a good place to take a break. We'll go into our first segment, and when we come back, we'll talk a little bit more about transporting over water and what people have access to in our state as far as transfers and best quality of care.
Sure.
Great. And this is Josh Green with Healthcare in Hawaii, and I'm interviewing today Dr. Linda Rosen. Thanks for joining us.
I'm Bill Spencer, president of the Hawaii Venture Capital Association. We do monthly luncheon programs with ThinkTech about things that matter to Hawaii entrepreneurs, investors, and business service providers. So join us on the fourth Thursday of every month at the Plaza Club. For information about upcoming events or to join our mailing list, visit hvca.org. See you there.
Aloha, welcome back to Healthcare in Hawaii. I'm your healthcare host, Josh Green. I'm an ER doc and a senator, and I'm hosting today with an excellent guest, Dr. Linda Rosen, who's in charge of the trauma system here in the state of Hawaii. When we last left off, we were discussing a patient that had gone from a small rural hospital, maybe where I take care of them with a head injury, to North Hawaii or to Kona, which has a level 3 designation as a trauma center. And it's now been determined for this patient that they really are going to need even more advanced care at our level 2 trauma center in Queens. So where we left off, Dr. Rosen was telling us how we might get that patient over here to Oahu. Linda?
So once the decision is made to go to Queens, or that they need Queens on a higher level of care, they contact the referral center there and then the trauma surgeon at Queens, and they have dedicated surgeons that are in the hospital 24/7 to take care of trauma patients. They would take the call and start gathering the information. And while the transfer is being arranged, they also can assist the referring physicians in their management of the patient. Mm-hmm. And one of the things that's happened with the trauma system that I think has been very beneficial is we now can transmit their images like a brain scan or a chest x-ray. We now have the ability to transmit those securely, of course, over the internet. And so the physician at Queens can actually be looking at some of those diagnostic studies and helping the referring physicians manage the patient until it gets to Oahu.
So we're continuing kind of up the food chain of people with more training. Is that what we're describing?
Right. Yes.
And when we talked earlier about the trauma setting in the rural areas and how it's much more competent now and they have more ability to treat people. Sometimes they're setting up protocols so that people don't have to be transferred if it's not necessary, again based on the best practices, what are safest for the patient. But now they get to a Queens hospital where they're a trauma 2 center. Now, we said that there are several levels, there's 1, 2, and 3. Why is Queens a level 2 and not a level 1? Tell people what that means.
Well, first let me just say that the difference between a level 3 and a level 2 is having that surgeon. The biggest difference, I would say, is having that surgeon in the hospital 24/7.
The trauma surgeon.
So it's not the 30-minute response time we have in the level 3s, but they're actually there physically in the hospital. One of them is there, at least one, 24 hours a day. And so then when the reasons that they would be transferred there is they have that capability, but even for a transferred patient who has already been stabilized and they don't necessarily need that immediate care,
right, then
a level 2 trauma center though can provide what we call surgical critical care, meaning very, very sick patient has specialists that are familiar with intensive care treatment, especially for trauma patients. And of course, Queens also has an array of subspecialists that may be important who are also specializing in trauma care, orthopedic surgeons, neurosurgeons, and those specialists, really important. So for the patient you described, they might very well need a neurosurgeon.
Right.
And so that would be part of why they would come to Queens. Now the difference between a level 2 and a level 1 is not really a medical care difference. So level 1 also has physician in-house. But the difference is they are more of, you might call a center of excellence, in that there are requirements. These are set by the American College of Surgeons, and we mimic them here in Hawaii. We pretty much accept everything that they use as standards. And they want to see research, and they want to see injury prevention activities, and they want to see leadership in trauma systems. So that's what makes a hospital a level 1, and we're hoping that Queens will become a level 1 soon.
Yeah, they've always been the standard of excellence here in the state of Hawaii, so we so appreciate what Queens does. And those of us on the neighbor islands, I can't even tell you, we appreciate everybody who will help us from level 3 on up. But when I need a patient to go to Queens, they're there. They're always there. Okay, so now we've established that a patient with a severe injury that's going to need probably serious surgery or an intensive care unit may very well end up at Queens Hospital. They're on the neighbor island still. We call the air ambulance, fixed wing plane, and if the weather's fine, if it's safe, they come quickly to get them. How fast does it happen?
Well, not as fast as we'd like, of course. You know, there's all these different pieces that have to occur in terms of, first, you know, we don't want to transfer patients that are unstable. So it generally takes, you know, an hour or so at least to evaluate the patient, you know, get the necessary tests and everything. So, you know, a couple hours gets eaten up pretty fast there, as you well know, in the beginning. But then we do have to fly the patients, and we don't usually have the option of flying them straight out of the hospital. They have to be driven in an ambulance to the airport, loaded onto an airplane, flown to the airport in Honolulu, loaded off the airplane into another ambulance, and driven to the hospital.
Yes.
And you know, this can be not uncommon, 5 or 6 hours before the patient will get here. Now, I mentioned earlier the helicopter at Kona. Now that could, you know, save 45 minutes of driving down to the airport. Also, helicopters can land on the helipad at Queens. Also can save some time, so you can shorten that. But it's still many hours, which is another reason, you know, we like to develop those neighbor island hospitals to be able to do a little bit more for their patients, if they can.
And I think that speaks to funding a lot of the time. And I know you've been very supportive by getting funds out to these hospitals. How do we get that funding? Where does the money come from for the trauma system? What kind of things do we invest in?
Well, we're really fortunate in the state, thanks to you and your colleagues, with our Trauma Special Fund, because we do have funding to make things happen that I don't think would come about if we weren't able to provide that funding. The Trauma Fund, most of the income comes from cigarette tax. A few years ago, legislature, which was a good public health move, raised the cigarette tax. It did bring in money, but it also cut smoking, so it's a good thing. And so we do get funding from that cigarette tax. We get a modest amount of funding also for some fines that are applied to things like, you know, speeding, assaults, and that kind of thing. But most of the money comes from cigarette tax.
Okay, and then you distribute that money when you see need in different places, like to get them certified to be trauma centers?
Right. So what we did is we started with these contracts or agreements with the hospitals, and we provided a fair amount of funding up front because we knew that they needed to hire, you know, a nurse to run their program, a physician to be their medical director, and we wanted to provide that funding, and so we actually funded them to work towards becoming level 3. We call it participation agreements. If they participate, they want to be part of the system, we provide funding, and we mean that funding to be level year after year, so they don't, because you know how it is, they'll say, oh, the state will give us money, but then they'll just take it away. So we're trying very hard for them to feel confident that they will continue to see that funding, that they can hire people and look to the future. But we also have funds that we provide for specific equipment requests, so that we look around, see, you know, where the needs might be, and we can provide a sort of, you know, one-time equipment purchase. And as you know, some medical equipment is quite expensive. And then we also have funds that we use to help them recruit and retain personnel. So we provided funding to help the hospitals attract orthopedic surgeons and general surgeons on the neighbor islands to help provide care.
See, this is all very interesting to me because the work that you do directly saves people's lives, which is, you know, I don't want to make you feel uncomfortable, but it does. I mean, you're able to take those dollars, and I think people often will say, oh heck, what are they taking my tax dollars for now? But this is a nice thing because, like, I had an aunt and uncle who died in a car accident on Big Island, and it happens, and it was just an accident. It's one of those things, and nothing would have helped them or saved them in that particular case. They were elderly, and it was a severe accident. But the idea that when we've said over and over again we don't have the ability to attract a surgeon to the neighbor island or even to Oahu, a certain subspecialist, that you can intervene with some of these tax dollars from tobacco tax and in a very focused way provide services for anybody that needs it. That makes me feel good because I think that that's a validation that sometimes we can make good decisions that help everyone rather than a small segment of a few.
I think definitely the trauma system is something that benefits everyone, and as you may recall, we are required, we don't provide funding unless hospitals provide care to everyone regardless of their ability to pay. And that's one of the reasons for the funding, is that it may not always be, you know, a money maker for hospitals to provide these services, but we want to take that issue away and make sure that the money is there to provide the services. And I think we've been pretty successful with that. The hospitals, you know, have come forward to reach that level 3 designation very pretty quickly. It only took 2 years. We first designated in 2011 on the Big Island, and Maui last year. So I've been really impressed, but I think my feeling is that, these services can benefit, anybody in the community. It could be their neighbor, their child, or anyone. And I think the healthcare providers in those communities have really stepped up to make the trauma services improved in their hospitals. I've been impressed.
I've noticed that people are, they're much more up to date on advanced trauma life support coursework. They are much more integrated with their other specialists across the state. I mean, it's been a very palpable change as a doctor out in the kind of the hinterland, so to speak, in emergency medicine. And I don't think we should fail to mention that we have 6 or 7 million visitors every year, and they, of course, benefit from the trauma system that we have as well. Anybody gets injured anywhere in the state if they're visiting.
Absolutely.
Right. So we
And
take
I
care
think
of
it
everyone.
is important
Yeah.
because that is, of course, our biggest industry. We should take good care of our visitors. We don't want them going back saying, oh my gosh, I didn't realize the services just weren't there. And yet it is hard because we don't have big population centers in some of our islands. So we really kind of have to stretch to provide the whole array of services. But one of the things that I think the system does, I have a little saying, we shine the light, which just means that we're examining what we do. We collect the data, we think about what we're doing, we document what we're doing, we talk about what we're doing, and I think that elevates the care because people are just really being a lot more thoughtful. It isn't always, equipment and resources. A lot of times it's really just being very thoughtful about how you approach things.
Well, let me ask you, before we head into our next break, kind of a general question. Has it helped? Are we seeing better outcomes for people that have had injuries? Have we seen any changes in the trends of people having severe injuries and dying, or severe injuries and then being able to live? Have you been able to see any data yet in these first couple of years?
Well, we're limited. We are a small number state, and I'm careful with data and calling trends too early, but I think we've seen some definite changes in some of our patterns. We know that the head injured patients, we sometimes used to get patients who had very slight abnormalities on their brain scans that weren't probably going to need any further care, but people might be uncomfortable, as I was talking about that before. So I think our guidelines, and we have documented that we've reduced some unnecessary transfers, and we've speeded up the necessary transfers. We can see that too. And we've improved the quality of information transfer between. We have also quality reviews that we do statewide every quarter. We came to the legislature a few years ago and asked for protection for those committees so we could freely, discuss cases among professionals and try to improve the system. And so we quarterly review cases together, and so we have surgeons and nurses coming from across the state to meet with the Queens folks. And also, I failed to mention, we have Kapiolani Medical Center for Women and Children is what we call a pediatric trauma resource hospital. They're not a level 3 because they're not set up quite yet to take the ambulance patients the way Queens is, but they have a lot of tremendous pediatric resources and some great pediatric surgeons, and they're an important part of the system too.
Well, I can tell you, one day, and maybe we'll end on this little story and then we'll go to break. One day I had a patient, he was 5 or 6 years old, and there's a family barbecue going on, and mom brought him in with a bandage on his head, and it was very bloody, and he had been hit by a horseshoe. And if you're on Big Island, those horseshoes are the real horseshoes, like about 8 pounds, and it just hit him straight on the skull, and it took a clean circular piece of his skull right out. And he came in, and again, it seems to be the theme for today's show, from his frontal lobe was exposed, and the kid was actually pretty calm, and I wouldn't say he was happy, but he was he was okay. Took that piece of bone out clean, and I was able to get Kapiolani and some of their experts on the phone right away, and they immediately set the emergency transport mechanism into motion. And I think it was about an hour and 5 minutes later, that young man was already over here and headed right into his evaluations and surgery. So it was extremely quick, and Kapiolani does an exceptional job in support. So it was really great to have them there as well. So I think, why don't we take a break now? I'm here, Josh Green, your host, Healthcare in Hawaii, with Linda Rosen, who is in charge really of the trauma system here in our state of Hawaii. After the break, we're going to look into some of the questions about the statistics, the epidemiology of injury in the state of Hawaii. Maybe we'll talk a little bit about car accidents, drunk driving, and we'll begin to explore the kind of things that she thinks we could do to improve our health and safety here in the state. Thanks for joining me again, Healthcare in Hawaii.
Aloha, I'm Nicole Horry for ThinkTech. For nearly half a century, the Hawaii Foreign Trade Zone No. 9 has brought the benefits of the Foreign Trade Zone program to Hawaii businesses and entrepreneurs. DBET, the Department of Business, Economic Development and Tourism, operates Hawaii's Foreign Trade Zone program to encourage international business and economic development. The Foreign Trade Zone's mission is to increase the amount of international trading activity in Hawaii, thereby providing employment opportunities for the residents of our island state. For more information, see ftz9.org. I'm Nicole Horry. Mahalo.
Aloha. Welcome back to Healthcare in Hawaii. I'm your host, Josh Green, emergency physician from the Big Island. Today I have Linda Rosen, physician who's also focused on these large issues of trauma in our state. For the first two segments today, we've been able to explore what it means to be a trauma center, what does trauma actually mean, and how have we been able to bring resources to our hospitals to make them level 3 trauma facilities to help make things safer in the state of Hawaii for both those who live here and who visit. But Linda's not just focused on the ambulance side and the hospital side, she's also focused on education and prevention. She has a wealth of experience in these areas, but she also has access to a lot of data about what happens to people in society and probably some of the challenges and threats to our families. So I'd like to talk to her a little bit about that now. Linda, why don't you begin to tell us, you have a background in public health as well, from Hopkins?
Johnson.
Yes, so one of the best universities in the country, for sure, and you've been able to take a kind of a broad look. First you started as a clinician here in the state, and now you're a director at the Department of Health. So what kind of things do we see in the state of Hawaii? What are most of the injuries like?
Well, one of the reasons I'm passionate about, the trauma system is the potential that it has, because injury is the leading cause of death and disability in folks from 1 to 44 years of age. And I think that although chronic diseases are very important, when you look at that age demographic, you realize that injury really is responsible for more productive years of life loss than any other, condition that we face. So when we talk about injuries and the burden to society, of course, head injuries, traumatic brain injuries are very important. The brain, I dare say, is the most important organ in the body. It's really what defines us as being human, and without our brain faculties, pretty rough. And yet we've been not very successful in quantifying that as much as, the numbers of deaths. But I think it's an important concept for people to remember that we're not just preventing deaths, we're preventing disabilities. So the big categories that we find need attention in injury are the ones people might typically think of, which are motor vehicle crashes, motorcycles, pedestrians, also falls, and what used to be the leading cause of injury, death, motor vehicle crashes, has actually been exceeded by falls now, particularly in the elderly. So that's something that is important in the elderly. And then another area that's really become more prominent and it has also exceeded motor vehicle crashes is poisoning. Some people don't think of poisoning, as an injury, but that is what it is, and it is amenable, hopefully, to some of the same approaches that we've used for preventing other injury areas, and working particularly in the prescription drug area, because we've seen a threefold rise in the number of deaths, I think, over the last 10 years, and really the most of it is due to the prescription drugs.
Interesting. So let's touch on both of those points. So first, let's talk a little bit about motor vehicle accidents, drunk driving, motorcycle accidents. Tell me about that. Are we high as far in the state of Hawaii versus other states as far as the mortality rate from car accidents? Are we low? Where are we?
Well, we're actually, compared to the rest of the country, a relatively safe state when it comes to motor vehicle crashes. I use crashes instead of accidents because we like to emphasize that it's really preventable. Accident sort of sounds like couldn't do anything about it. So anyway, the crashes, our crash rate is better than the United States as a whole, but we have some disparities between Honolulu and the neighbor islands. We have higher motor vehicle death rates on our neighbor islands than we do on Oahu. And of course, we don't understand, completely why that is. It might be due in part to some of the care issues that we were just talking about, but it also is likely due in part to the higher speeds that can be sometimes achieved on those long stretches of open road, and there just is more road. The more you drive, the more you're at risk for injury. But of course, there are areas that we're very concerned about and still trying to control, because impaired driving contributes so much, to the crash rate. So we're still working in that area, but we're actually overall better than the country as a whole. Falls in the elderly, that's a problem across the country with our aging population. Of course, as we do better with some of our other diseases that affect the elderly and they live longer, but they're fragile, and so they, as you know, can get pretty serious injuries even from just ground level falls and things that don't seem like serious mechanisms. So that's a real challenge for us. It's a challenge for the in prevention, and it's a challenge for the trauma system in really figuring out how to take care of that particular population when they're badly injured.
Fascinating. So just so briefly, on Big Island, on other islands where we're further away, I guess it would stand to reason if you're an hour away from any hospital, let alone a trauma-3 facility, that might add to your risk of dying from a car crash? Is that
Definitely.
And then how often is alcohol or drug involved with these accidents?
Pretty frequently, and depending on, I think if you're looking at drivers in particular, and when we look at the trauma registry data, I don't have the exact number, but being impaired, that means having drug and alcohol on board. It's about 43% in the trauma registry of those who are, admitted, serious enough to be admitted to the hospital. So it's pretty high.
I know that 1 year on Big Island, the rate, the percentage that drugs or alcohol were involved in the fatal car crashes was 57%. And that was, I think, 2 or 3 years ago. So that remains a big challenge for us. How have the laws that we've passed made a difference as far as, for instance, the interventions where people have to blow into a device, to be able to operate their car?
Right, that's the ignition interlock, and that's still relatively new, so we don't have a lot of data to evaluate that particular one. But of course, we always look at different strategies to reduce, the impact of impaired driving. And in general, I think it's good for the public to know that whenever we look at policy changes, there's two components that really affect how successful it is. One is enforcement, and the second is consequences.
Right.
So we keep kind of looking at those issues to say, how can we, get people to change their behavior and be safer drivers.
You're very big on health education too, is my understanding. Talk about other issues like helmets, motorcycles and helmets. Is it important to wear a helmet? Is it going to save your life? What's your experience been as a public health person?
Well, of course, helmets has been controversial, but there's no question that they can protect from the severity of injury. Of course, they're not 100% protective. We have, motorcyclists unfortunately die with their helmets on. It does happen. But they are protective, and we've done some recent studies by linking our ambulance data to hospital data to really quantify the cost of actually unhelmeted riders, so that because our hospital database contains how many dollars were charged for the patient, how long they stayed in the hospital, and who paid the bill, Medicaid or self-pay or insurance,
Right.
we've been able to show that there's quite a bit of cost, not to mention the tragedy that's preventable, but there's true cost to society and allowing folks to operate these transport devices without helmets.
Going to be an ongoing debate for sure.
Yes, it is.
Tell us more about poisoning. So you were saying that it's prescription drugs that have been a big problem. I think we've discussed this a little bit in a different context on some of our previous shows. One thing that came to my attention at a conference recently was that 85% of all opioids, that's morphine and those kind of drugs that are prescribed in the world, are consumed by Americans. 85%. And we're not a small country, but we only have maybe 350 million people, a small percentage of all of the population in the world, but 85%. What's going on with that? And are we a culture of addiction? Is that why we're seeing these poisonings? What can we do about it?
Well, I think we're really not clear on all of the things that have driven this, but there's no question that with the number of increasing prescription deaths, it's parallel increasing prescriptions. So the rate of prescribing narcotics, and this is not, buying them on the street or anything, this is physicians writing prescriptions for narcotics, has just gone up tremendously in the last 10 years. Now, some of that, a small portion, may not be necessarily bad. As you know, as a physician, people have talked a lot in maybe the last 10 or 15 years more about pain and the fact that maybe sometimes people are undertreated for pain in a medical setting. But I think most people would say that the things have swung too far in the other direction and that we may be over-treating pain or prescribing things for pain which really are not addressing the underlying problem.
One time I was on the road driving back from a shift. I just finished an ER shift, and this individual was driving really crazy on Queen K Highway on Big Island. And all of a sudden she goes off the road and into down a hill and into a lava field, and her car light's on fire. So I pulled over and I jumped down there and I pulled her out and I called 911. She had a badly broken wrist, and she was slurring her speech, and I was worried that she had injured her head, so I did all the things that we're trained to do, secure her neck and keep her calm. Her car was burning. It was a very crazy situation, and sure enough, it turned out she was taking a lot of OxyContin, big doses of OxyContin. It was in the middle of the day, and she was basically passing out at the wheel of her car, and that's what caused her accident and injury. And thank goodness she was fine. The great docs that were actually on duty up at Kona Hospital, they took care of her immediately and they fixed her and so on. But it wasn't a head injury, it was essentially the poisoning. She ended up having to go through detox for her drug prescription after her injury. So these stories, they seem to meld into one another.
Right, so there's a lot of concern out there, and we're looking at different ways to try to improve the situation. I know there's a lot of physicians out there who they are trying to do a good job.
Yes.
But narcotics are extremely powerful drugs. Folks can easily misuse them, not just abuse them, but really misuse them and not intentionally die of an overdose because they just don't understand, especially when you combine narcotics and tranquilizers.
Yeah, that's been a big concern. And in the past few years, I think we've tried to be more attentive to this problem, and the narcotics enforcement folks are now able to track prescriptions a little bit better here in our state.
Yes, they have a database that actually all prescriptions for controlled substances are on that database. One of our strategies is that we'd like to encourage physicians to check the database when they have patients that they're considering prescribing opioids to. Some people have had concerns about emergency physicians,
Yes.
but nationwide only about 6% of narcotic prescription are written out of emergency departments.
Good to know.
So, and yet they are the ones who are usually most sensitive about drug-seeking behavior,
Right.
because they're used to that kind of thing and they're kind of alert to it.
Yes.
But other physicians need to be thinking about that, even with patients they might not suspect of being drug-seeking, including little old ladies, things like that.
I know, and those drugs don't often stay with the patient they were prescribed to. We know that they get into the hands of family members or friends, and it's hard when people are addicted and they end up seeking out those medications. I know on the Hilo side of the Big Island, people were concerned because there had been a brief rash of young people crushing pills and pouring them into Coca-Cola and sipping the Coke all day in school or in breaks during the school day, and they were getting high off of these narcotics. And it creates a lot of challenges, and it's kind of heart-wrenching to think of our children being exposed to some of these drugs when we can clean up some of these problems ourselves.
Yes, definitely.
So I think what we're going to do is we're going to head into our final break, and then we'll come back for 5 more minutes of wrap-up. But it's been a terrific discussion so far about the
Thank
trauma
you.
system in
Thank
Hawaii. Great. Again, this is Josh Green with Healthcare in Hawaii. We're with Linda Rosen talking about trauma in our state.
Aloha, my name is Dan Bauer and I'm the General Manager of the Plaza Club. The Plaza Club is Honolulu's premier business club. We're located in the heart of the financial district on historic Fort Street Mall. On the 20th and 21st floors atop the Pioneer Plaza, our commanding skyline views, along with our award-winning cuisine and service, are known as the place to do business downtown. We offer professional as well as social events and programs to our members and their guests, all tailored to enrich their professional and personal lives and to give them the cutting edge that they deserve in business. Why don't you consider becoming a member of the club? Call me at 531-7788 or come see me and let's talk business and how the Plaza Club can work for you. Again, my name is Dan Bauer. I'm the general manager of the club, and I'm here for you.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, chairman of the Health Committee in the Senate here at our state and also an ER physician. Today I'm joined by Linda Rosen, a fellow physician in emergency care, but who runs the department that's in charge of the trauma system for the state of Hawaii. In our first three segments, we've been able to discuss what it means to have a trauma in the state, what our hospitals do, and what the difference is between a level 3 and a level 2 trauma center, which is what Queens is. We've talked a lot about injury prevention and talked in detail about injuries as in traumas in the car accidents, sometimes caused by alcohol or drug abuse, sometimes just falls because our elderly population is having more injuries of that sort. Then we switched over to poisoning, which is also a part of the branch that Linda is responsible for. There's been an uptick of 3 times increase, higher increase that is, to see poisoning from prescription drugs. Those are pills that people get prescribed often by physicians or they get off the street, but mostly by prescription, and how that's impacting society. But I want to bring the conversation back now, since we have our expert here today with us, to what's next. What's the future hold for the trauma system in the state of Hawaii? And we're really going to focus on Oahu, where most of our people live. So Linda, why don't you tell us what's next for Oahu? What are we going to add as far as services, and what can we expect?
Well, yes, so we spent time talking about the needs on the neighbor islands, but we have to remember that the majority of the population lives on Oahu, and we've only had one trauma center available to that population. And Queens does a terrific job, but if we have a sudden event, a mass casualty, or even just 3 or 4 cars crashing at the same time, it is challenging when you just have one trauma center to be able to address that. So one of our goals has been to have another trauma center on Oahu. I mentioned that, we do have Kapulani for kids, but we really need another center that can take adults. So we're hopeful that the new hospital that's going to open out in West Oahu next year will be a level 3 trauma center. We've been talking with Queens about that. I'm very hopeful, and it'll definitely be a great addition here on we need a hospital there, as you know, very badly for various reasons. But if it can also be a level 3 trauma center, it'll be a great backup to Queens. We want patients who are injured to have access to the best services, and we're not trying to restrict them from the level 2. We just want to make sure that we have enough capacity, to serve the population here on Oahu.
And it's my understanding that the way Queens is structuring their plan is they're going to have physicians that are credentialed at their main campus here at Queens downtown, also working over in some degree over in the other campus. So it sounds to me like you'll be able to use a lot of that hard work that you've already put into Queens over the years to continue their accreditation as a level 2 trauma facility, to also educate, train up the staff over in West. Is that the plan? Right,
and I think they are going to share some staff, and in any case, all the expertise that Queens has, I think that can lend to the new hospital would mean that, their startup time and ability to develop a trauma service should be, pretty quick, because they've got all those resources to assist them at Queens downtown.
When the hospital closed, I understand that people had to be transferred all to, to the other emergency rooms. Did that cause a big problem?
Well, yes, it's really been a capacity issue on Oahu, because without the emergency department, particularly out in West, we had 2 hospitals closed, so we had decreased emergency department capacity and also decreased beds available to admit patients to. So both of these have been a real problem, and it's just, you subtract a certain amount of capacity and it puts a burden on all the other remaining hospitals. So they've had a lot of issues with keeping their emergency departments open to ambulances and handling that extra capacity, the extra number of patients.
So in your capacity as the Chief of Emergency Medical Service for the state, you must be excited that...
that hospital can't open fast enough for me.
Okay, well, I think that's really a pretty good place for us to wrap today. We're looking forward to the Queen's approach over on West. But we're so grateful to have had you here today to describe what trauma is in the state, what we have as far as our capacity to take care of people, and in some ways what we can see in the future. So we will bring you back to talk more about trauma and injury in the ensuing years as we see our system grow, mature, and develop. Thanks
so much for the opportunity.
It's great to have you here today, Linda. Okay. So we're going to wrap today. This is Josh Green, Healthcare in Hawaii. We'll resume our talk about healthcare transformation later in the month, but today we've been honored to have another physician who works in a strategic way to bring trauma services statewide to both those who live here and visit here in the great state of Hawaii. Thanks for joining us, Healthcare in Hawaii. I'm Josh Green, your host.